for their input. I'm happy to present on behalf of Nana K. Shelburne, who's in the Epidemiology and Genomics Research Program, and Erica Breslow, who's in the Healthcare Delivery Research Program, and Asad Umar in Division of Cancer Prevention. This is in direct result of the recommendation in the Blue Ribbon Panel and the prevention and early detection of individuals at high risk for cancer to sponsor initiatives to improve the current state of genetic counseling and testing, prevention, early detection, and knowledge landscape for those with an inherited predisposition. It's addressing the first two goals that they had on a list of goals in that recommendation to increase case ascertainment for proband and at-risk relatives and to improve the delivery of the evidence-based services, including genetic counseling through prevention, early detection, and ongoing surveillance. This was centered in a background that was highlighted in the report, that inherited susceptibility to cancer occurs in about 10% roughly of all cancers, and that there is a clear underutilization of cancer genetic counseling and testing. Cancers can be associated with multiple genetic syndromes, and it's important to note that cancer counseling, genetic counseling has been around for over 2 decades now, but there's been a clear increase in the complexity of that landscape from single gene testing to multi-gene panel tests and now the introduction of tumor sequencing. So just to give you a little bit of an overview of what happens in the clinical setting, people may come to attention because they are diagnosed with cancer at an early age and or have a family history of cancer, or people are at risk with a family history of cancer. They'll go to their healthcare providers, have a referral to genetic counselors. Genetic counselor for those at risk will determine if a family member should be tested to give the most informative testing, or they may consent to test, or they may choose not to test. It is a choice to test. Whether or not they test or not, they should all have follow-up care. If they have a consent for testing, they may get informative test results, a positive or a negative for a mutation, or they could have a variant of uncertain significance. Again, in any case, there should be communication of those results with family and appropriate follow-up for all involved here through their healthcare providers. There are times that people are lost to follow-up. They choose not to follow up with referral or testing in both the patients here and among family members. So the importance here is to improve overall ascertainment in this healthcare delivery. This was complemented from the Blue Ribbon Panel with a workshop that was held with a focus on Lynch syndrome, but they were charged with addressing more broadly inherited syndromes. The takeaway message is that there should be a broad-based screening approach for hereditary cancers because people present broadly with broad family histories. There should be consideration of multiple paths for ascertainment, emphasis on sustainable care delivery, making sure that there is follow-up care. Multiple approaches are required to meet the needs of a variety of healthcare settings. We had a very interesting presentation from a rural physician, family physician on that, and of course addressed diverse population settings. We had very interesting projects presented for the statewide program that was conducted in Ohio focused on Lynch syndrome, some from integrative healthcare systems, and also Canada that's involving a demonstration, a clinical output on a population based for Lynch syndrome. The gaps that were noted were making sure that there is follow-up care for all. It has to be sustainable in our whatever environment we're existing in. Implementation in diverse healthcare settings, and we have to incorporate real-world approaches that will make this sustainable. So to address these, we are proposing an RFA with the aims to develop and test strategies to increase case ascertainment of hereditary cancers through different approaches, develop and adopt evidence-based healthcare delivery models for cancer prevention and detection and cascade testing of at-risk relatives and follow-up care, test sustainable strategies to improve implementation across diverse healthcare settings and populations, and ultimately will identify metrics for successful and sustainable ascertainment, consultation, and the interpretation of genetic test results. Research interests we have listed include but not limited to, and based on our discussion prior to this, we've added a few things that will be added to the RFA concept, but they must address at least 2 healthcare delivery settings, include a spectrum of hereditary cancer syndromes. We're not focused on one specific type because that's not how people present. That's not the real world. We want to focus on the continuum of care, determine the best strategies for coordinated care and sustainable ascertainment through follow-up, outreach to diverse communities, racial, ethnic minorities, low socioeconomic, rural, et cetera, across a variety of settings. These, based on our discussions prior to this, we will include highlighting, looking at behavioral and psychological impact on the patients and families. And an important point is care transitions. An example was given as you go from pediatric care, your family's been tested, you have this history, to make sure that information and follow-up care is not lost in that transition to adult care. We want to solicit multiple PI UO1 applications. This does require multidisciplinary expertise to cover the challenges across care coordination in the patient population. And through the UO1 mechanism, we can facilitate work across studies, and we have expertise to provide with healthcare delivery and dealing with consortia. We will require that funded investigators plan to meet annually to share their successes and challenges. We will require data sharing with existing resources that we have. The funding requested is $4 million per year, which we anticipate could fund up to about 4 applications. We will evaluate success by looking at the data sharing across the funded sites and more broadly to the general research community, and we can assess this by enhancing existing data repositories. We will look at research productivity and impact of those funding findings. We will look at the increase in implementation science applications. We think this will foster additional work in this area for implementation research. And we'll look for evidence of increase in sustained clinically justified referrals for genetic counseling and outreach to diverse populations. There aren't really a lot of active grants in this area, and none that really look at this in totality of healthcare delivery. This one focuses on hereditary breast and ovarian cancer, looking at improving accuracy of risk perception, but also facilitating uptake of identification of family history and uptake for chemoprevention. This one we co-fund. It's looking at heart disease and selected cancers, again, including different methods of collection, patient-driven, but not the totality of healthcare delivery as such. So in summary, we're looking to improve the current state of genetic counseling and testing and emphasize sustainability and follow-up care for high-risk individuals in a variety of care settings. We want to test and disseminate methods to improve ascertainment and delivery of quality, evidence-based care, and encourage the development of sustainable approaches in diverse healthcare settings. This investment, we hope, will support scalable approaches for a variety of practice settings. As I said, we had a great conversation with the subcommittee. To emphasize a broad approach to inherited syndromes, not to focus on very specialized inherited cancer syndromes. That's really not what we're looking for. We're trying to improve care across different settings. As I mentioned, including these transition points in care and vulnerable periods, and including the human behavior component to look at the impact of counseling and testing on patient and the family and how these responses may differ across these populations. Another consideration that was suggested was to consider stagger RFA release with 1 to 2 grants in year 1 and remainder in year 2. I think that is a good idea, and they raised some issues with the budget. And that's it.
Okay, Dr. Thompson.
Well, after 30 hours of trying to get here, it's nice to be able to say something. But I want to thank Kathy for, we had some exceptional discussions on this, and I want to thank her and Dr. Smith and Shannon. My battery's dead too, so I have to read off this. Kathy, would you go back to the aims slide? Because it's important to understand that it has 4 aims, and each of the applicants, the respondents, is going to be responding to all of those. So using the earlier metaphor of Epcot, this is Epcot, Disneyland, Universal Studios, and SeaWorld, all in one application. So we felt that this was a significant opportunity to improve outcomes at a population level, as well as an area of investigation for which traditional funding opportunities are not available. And it's important to understand that all 4 of those will be responded to by each application. We discussed the definition of inherited cancer syndromes and felt that it was important to define clinically in the application to ensure that applications are fully responsive. Brought up during our conversations were syndromes such as neurofibromatosis, in which case ascertainment is obviously dramatically different than in syndromes that do not have a phenotypic association, perhaps like Lynch syndrome. And it was concluded that the RFA has to stress the importance of including all the aims in applications. As Kathy pointed out, we thought that human behavior investigations, such as how investigations of family members might receive testing information and how these responses might differ across populations, such as different rural communities or different ethnicities or cultural differences. And these need to be included in the RFA as well as in the applications. And finally, as Kathy pointed out, this is a very, very small number of applications, and as a result, it's going to be very, very important that the RFA and the review process get it right. And so we thought about the possibility of perhaps 1 the first year, test that, see how the response, and then a staggered, as Kathy pointed out, a staggered evaluation afterwards to get the biggest bang for your buck, the biggest return on the investment. And I'd like to thank my co-reviewers.
Anything to add?
Yeah, that was a great summary. Ian did a really good job of organizing all of our thoughts. I think the only thing you left out was we feel like this feel this is a really important initiative, and there are lots of families out there with potential cancer predispositions, many of whom may lived in rural areas or be in underserved populations. And we just thought that $4 million a year for this kind of intensive one-on-one interaction with these families and follow-through seemed pretty modest, and we were hoping to at least have a discussion about adding a couple of $1 million a year to this particular RFA. But I know that resources are short, but this really looked very underpowered, not for the technology costs, but for the people costs of actually grinding through this sort of stuff with families.
Dr. Smith?
The only thing I would like to add is when we're looking at behavior, if they would please study adherence, why people adhere or do not.
Okay, would you, Dr. Thompson, make a motion? Move for approval. Second?
Second.
Okay. All right, it's open for questions or discussion.
So is this a population study or is this a targeted protocol accrual? I mean, is there a pre-screen that gets them into this? Or are we going to survey a bunch of people and try to put it through it? Because that makes the resource piece of this even more daunting.
So the intention here is to really develop the process to improve ascertainment. So it's not a protocol. We're not setting out to identify everybody in the U.S., but we want different systems. So it was pointed out, we had a speaker from rural Maine, the challenges of rural Maine population in a primary care setting. And so they could come up with different systems that could work in their healthcare system to improve the whole process, to improve, which is different than an urban setting that I dealt with in Baltimore, and just that process. So that it's really healthcare delivery. They have to develop their methods in their setting.
So I guess I don't know if you got my question. How does somebody get to this?
It's a canary.
How do you identify the cohort that actually then can be studied?
So we're not, this is going on clinically now, for example, so not efficiently. So for example, in a community setting, people are referred all the time for genetic counseling, but we may be missing, this is what Ohio State was working on, to have the tumor-based testing in Lynch syndrome, that you get that communication from the pathology to make the referral, then to make that follow-through, and so that's that process. So we're not developing a cohort as such. It's really to test the methods to have in different healthcare settings to improve the delivery of this service.
Yeah, my understanding, I don't know, Ian might comment as well, but my understanding was that this was going to be based on sort of the clinical problem. That is, the patient who's diagnosed with colon cancer in their 30s and has Lynch syndrome, and how do you transmit that information to her and to her family members? Or, you know, the adult who turns up and at a physical exam in rural Maine looks like he has neurofibromatosis. So, you know, how do you do cancer genetic counseling, and what's the appropriate sort of systems to put into place to get people tested, informed, tested, counseled, and then it's not population-based. Yeah. Correct. It's canary in a coal mine. Yeah. How do you sort of try to do this efficiently?
But it may be different in different settings. As Kathy pointed out, there will be a requirement, if I remember, of at least 2 settings for each application. Right. So it will be looking for best practices. And there will almost certainly be metrics built into this to identify the best practices, which may be different in different settings and different disease processes.
So I am a little confused now, because I am part of the Ohio initiative, and our paper was referenced, so it's public knowledge that I am part. And we recruited 3,300 colon cancer patients and tested them not only for Lynch but a whole host of hereditary cancer syndromes, and we actually found more than what you would expect, and a lot of more who would not have been identified, to be tested. So I think if we want to achieve the goal, we can't necessarily just do clinic-based testing, because clinic-based testing is extremely biased, not only by race, but we haven't even talked about ability to pay for both the testing and the counseling, as well as any privacy, legal issues, et cetera. But anyway, I think we have to get out of the box. We have to get out of the box with this clinical model of just testing people, who look like they might have Lynch syndrome or might have breast ovarian, syndromes. Or we're not going to move the needle. We're just not, and we're not going to do what we wanted to do in the Moonshot.
So, Electra, I would say the intention is not to follow that you're saying, the clinic-based, because one application could be taking what lessons learned in Ohio and doing in that setting, which is a tumor-based testing for Lynch, but also people still present with a family history, so you don't get away from that. So I don't think that's not the intention to exclude that, right? So just so we're clear that.
Good then. So that's it. But cost is going to be an issue, all right? So I wonder how you're dealing with cost, because the cost of the testing and the cost of the counseling.
Can I add the cost of the treatment if you find something?
So that's the real world, and I would say we deal with that daily now, those of people that are doing this. So I think the challenges are to find out how to keep doing that and make that sustainable, and it's going to be more of a challenge, perhaps. We don't know. So I recognize that's an issue, but that's part of what has to be looked at in different ways to improve that, to make it scalable and accessible.
Is it on now? I just wanted to amplify what you were saying in terms of, Mary Claire King has been calling for population-based testing, at least in some populations, because of high carrier frequencies. And doing an implementation type of study in this format might be very helpful. Looking at, testing men and women in the Jewish population for BRCA. I mean, there are economics saying that the time is right for something like that, and looking at an implementation in this setting may be right. And then getting back to the funding and the cost. Even if you have 3 daughters with, who have BRCA, then the obligate mom who is Medicare can't get tested through Medicare. So I think thinking about the funding mechanisms, and then the real world aspect of our new health care. Is this a pre-existing condition? What's that going to mean in terms of privacy? And I think those are really very significant concerns in the ethics of it in putting it forth, and we need to see what's going to happen with our new healthcare funding in terms of how
I
we
think
roll
this will work out some of those issues, and I'm going to provide
Are we putting them
information.
at risk by testing them?
Pardon me? I didn't hear.
Yeah, a question for you. I think the phrase care coordination came up. Do you envision applicants being part of a formal care coordination program or network within their institutes, or are you referring to that as sort of care coordination in little c quotes?
I say little c. I mean, what isn't done well, I think, is always coordinating care. So that is something, and that will vary by setting. It's going to be different in the Kaisers of the world or Geisingers of the world and versus those in a rural primary care health setting. So I think that's going to be information provided from this, in my opinion.
Quick follow-up. To me, how that shakes out in the applicants in many ways starts to address some of your questions, because that'll define where the handoff points are, where the barriers are. You won't know until it comes in.
Yeah,
It is that intersection of
that's
your world.
Charles.
best practices, yeah.
This may seem tangential, but I think it's related to your out-of-the-box question. So at MSK, I think a lot of you know, using the MSK Impact Panel, we've sequenced about 18,000 patients with matching normal. Ken Offit has recently done an analysis of, I think, 4,000 or 5,000 of those who were consented to get the germline results returned to them, and the frequency of canonical risk alleles in BRCA, et cetera, that there's no argument about the pathology associated with the allele is at least twice the expected rate, and a lot of these patients don't have any family history. So I don't know if that's related to what you're trying to get.
Well, it's related. That certainly came up in the workshop, and what we don't have a good handle on are penetrance, because the initial studies were finding the mutation and their high-risk families, and so now you have, as you're discovering, different alleles, no family history. What does it mean? So that's a separate. That's not going to be answered by this one, but that is following up. Perhaps maybe there'll be another one
There'll be an
next
avalanche
time.
of this data. It already exists.
Okay. Ian, would you like to modify anything at all? Still motion to approve, right? So this is what we're going to vote on. Yeah. Okay, no more. All right, so I'll call this to a vote. All those who approve? Any against? Abstention? Okay.